Good morning, colleagues, and welcome to this webinar. The name is Charles Gilbert. I'm responsible for human resources at the Faculty of Health Sciences. This event came about in consultation with human resources and the communication section at Central. And we thought it was important that we give staff a platform to address concerns and perhaps interests in how to be safe in the workspaces. So we already have an array of questions submitted to the panel of experts, which will be introduced by Prof. Mahdi pretty soon. University has a panel of experts to deal with those, and we will certainly answer all the questions, or perhaps try and answer all the questions that's submitted through the chat box, and we invite also staff to submit for any further questions, should there be any, through the chat box. So Prof. Mahdi, without further ado, I'm handing over to you to introduce the panel. Thank you. Prof. Mahdi, over to you.
So thank you, Charles, and good morning, colleagues. Thanks for joining us this morning. So I'm just going to start off by quickly introducing the panelists on today's call. My name is Prof. Shubir Mahdi. Obviously, I'm the Dean at the Faculty of Health Sciences since the beginning of the year. And then other panelists that we've got a pleasure of hosting today is Dr. Madhu Masilela, who's a principal investigator working at the Sechaba Research Center, which is based in Soshanguve in Pretoria, and he's been working on COVID-19 vaccines. Then from the Charlotte Maxeke Hospital, an academic head of emergency medicine at the Wits Medical School is Professor Rosa Mutara. And then Professor Lucille Bloomberg is based at the National Institute of Communicable Diseases, and she's really a veteran of outbreak responses and has been an advisor to the World Health Organization on a number of different outbreaks. So it's a pleasure to invite you to today's, to have you on today's webinar, and let's get started. So I'm going to first just perhaps ask Prof. Bloomberg, Lucille, if you don't mind, perhaps just giving us some sort of a sense in terms of where we are with the pandemic in South Africa currently, and perhaps look in your crystal ball and tell us what to expect in the next few weeks or months.
Yeah, I wish I had the right crystal ball, always difficult to predict. So the second wave has subsided. It certainly was quite a hectic second wave, developed very quickly and came down really quickly, definitely higher than the first one with more deaths. And I think it was precipitated by new variant, but particularly by super spreading events around the holidays and the festivities, where people got together, and it was the perfect setting for transmission of virus, particularly the new variant. So we are between waves. I think there are in the region of about 1,000 confirmed cases every day. Remember, this is just probably an underestimate because not everybody gets tested, but there is still circulation of virus. And it's difficult to predict when the third wave will come. We will have a third wave, and it really will depend on what happens now in terms of our own personal endeavors to reduce transmission and adherence to many of the measures that we're going to talk about, and then also about the rollout of the vaccinations. So we can have a big effect on this third wave, and we need to make sure that we try and manage it. So I think that's the crystal ball.
Yeah. So perhaps just to follow up on that, within a workspace environment, what do you think are the big ticket items that we need to be looking at to try to minimize the impact which a resurgence would have, or us contributing to a resurgence?
So I think we can make the workplace safe. And there are many things that we're going to discuss today that can be applied, and that definitely do work. I think the big problem is people have COVID fatigue, and they see the numbers coming down, and they think it's time to take off the masks and get back to being sociable creatures. I think that's not the case. We absolutely need to manage COVID transmission by applying the non-pharmaceutical interventions, which absolutely have an important impact if we apply them properly. Masking, distancing, reasonable, attention to hygiene, and no super spreading events and gatherings should be held. And this is going to have a major effect. And then I think vaccine rollout is going to be critically important in our way forward.
So, and I think the point that you make about mass gatherings, and I think that's especially something that's important in the workspace. I know even at medical school at one stage earlier this year, as an example, the tea rooms were being kept open. And obviously those sort of gatherings in closed, poorly ventilated areas where people are not going to be wearing a mask because they're having lunch together lends itself to increase in terms of transmission taking place over a short period of time. So I agree, that's something that we really need to be vigilant on. And there's no way that even with the level 1 restrictions that we should be allowing those sort of gatherings in indoor spaces which are non-essential, and especially where face masks are not going to be used.
Outside.
Firoza, so from your perspective as head of emergency medicine, has there been any sort of take-home messages that you've appreciated during the course of the resurgence, either in terms of the type of people that were ending up being admitted in hospital, or do you think that the risk factors associated with the illness has remained relatively unchanged compared to what we experienced the first time around?
Thanks, Shabir. So I think for us, just having gone through that second wave and having been on the forefront of dealing with it, this was a group of patients that were younger than the first wave. So, sort of 30s on upwards to about 60s, whereas the first wave was particularly the elderly patients with quite a few comorbidities. So people with high blood pressure, with diabetes, with underlying lung disease were the ones that were affected in the first wave. With our second wave, it was pretty much healthier individuals with not many comorbidities or no comorbidities, and they came in relatively sicker than patients with the first wave. Now, whether that was because people waited particularly a long time before they actually came to hospital, and presented later in the illness process, or whether it was just the nature of the variant that was the cause of much of the infection and the presentations with the second wave, we're not quite sure. But definitely the patients were a lot sicker and a lot younger than the first wave, and again without comorbidities. So I think we need to be mindful of the fact that, as Lucille was saying, a lot of the outbreaks that happened with the second wave were from super spreader events. And they were particularly with young adults, young teenagers, adults that had big gatherings and parties and end of the year raves, and then came home and spread those infections to the older people or the adults at home. So I think we just need to be mindful that the vast majority of people do get asymptomatic infections. And, they may have a mild flu-like illness or sometimes no symptoms at all, and are unaware that they're carrying the infection and then take it home to people who might be more susceptible. So, not just the staff, but our students as well that attend are potentially spreaders of the COVID infection. And definitely, as Lucille said, we found that even amongst our staff who are particularly careful about wearing proper PPE and treating patients, when we go into these troughs or the where the peaks are over, people do become lax. Part of it is COVID fatigue, but also people just, there's not that much COVID around, so we don't have to worry about wearing a mask. And I agree with Prof. Mahdi, the tea rooms are particularly a big issue for us in the hospitals, and I think in the office buildings as well. People stand in corridors or sit in the tea room, and they forget that when you're talking and when you are sitting opposite someone at a table in the tea room, that's when you're most susceptible to spread COVID if you have it. So I think all the lessons that we've learned, and we know for sure, the things that work, we still need to be practicing going forward. Thanks.
Thanks, Rosa. And I think it's very important to emphasize the point that we're not asking people not to have tea and not to have lunch, but when doing so, have it outdoors. Because what we've learned about this virus is that most of the transmission usually takes place in indoor, poorly ventilated areas. So it's just being wise about what we do and where we do it, rather than not doing it at all. So, Prof. Masilela, so would you like perhaps just to reflect on what we've come to discover over the past few months, or even not few weeks, when it comes to COVID-19 vaccines in the context of the variant that's currently dominating in South Africa?
Thank you, Prof. Madi. In the context of the variant, I'll first start by informing our audience that we're currently doing a number of COVID vaccine studies that are looking at different vaccines. We were currently doing your Oxford study, which is looking at the AstraZeneca vaccine. We're also having another study looking at your Novavax, which is another vaccine, as well as your Ensemble study that is looking at the J&J study vaccine that's currently being rolled out. Of note is that we found that the Novavax vaccine, as well as the Ensemble study, has shown a 60% and 57% efficacy with regards to preventing COVID, especially with regards to the variant as well. But unfortunately, we found that the AstraZeneca vaccine did not show any efficacy with regards to the variant, but it did show a remarkable efficacy against the wild type, which is the original COVID-19 vaccine virus that was ongoing before the second wave. So in actual fact, that is why now we are seeing a push in the country, where now government is obviously promoting the rollout of the J&J vaccine, which has shown that it is efficacious against your original virus as well as the variant. And this is an ongoing study, obviously. We would like to see because what I'd like to state is that the vaccine had been tested in South Africa and in other 4 continents, especially the J&J one, where it was tested in about 43,000 people from 4 continents. And then in South Africa, it was tested in around 6,576. And it was found that it was efficacious against protection for moderate to severe diseases, about 57%. And for severe disease, it's about 85%. And it was found that it had 100% protection against death, which means out of the 6,576 participants that got the vaccine, the J&J, none of them succumbed to the disease. So I think that is what is now, that is why this J&J vaccine has been pushed to cover all our healthcare workers. And just to note, it has not yet been approved, hence it's still in the approval process. And that is why the healthcare workers still need to give consent to receive the vaccine in a way because of that. So I'll end there.
Thanks, Dr. Masilela. So just to sort of also add to that, with the AstraZeneca vaccine trial in South Africa, what we were really looking at was protection against mild and moderate infection, which the vaccine doesn't work against due to infection by the variant. But the World Health Organization has indicated that even in countries where the variant is circulating, they should still use the AstraZeneca vaccine because it's a strong biological possibility or plausible reason to believe that the vaccine will protect against severe disease. But as you mentioned, with the J&J vaccine, we've got more conclusive evidence that it does protect against moderate to severe disease. But I think what we need to emphasize is that with all of these vaccines, these are not vaccines that will necessarily prevent people from getting infected, at least not by the variant circulating in South Africa. Even the J&J vaccine The greatest benefit for these vaccines currently are for high-risk groups, people that are at risk of developing severe disease. So we just need to be guarded in that even if we get people vaccinated, they're still needing to take precautions because they might still be at risk of developing mild infection, but fortunately they'll be protected against severe disease. So for the audience, for the participants, you're welcome to just include questions on the chat. We do have some questions on the chat and a Q&A. In addition to which we've had a number of questions that were actually submitted, which I'll also go through. So Lucille, perhaps, so a question in terms of general health, can a COVID infection trigger other illnesses that were not present before in an individual?
I'm sure Verosa can add to that, but we've had a number of patients who've presented for the very first time with diabetes. It's kind of precipitated their diabetes and quite severe presentations of diabetes when they develop COVID. So I think that is the one that's kind of come out. For the rest, I think not many other examples. I think diabetes would be the most important one that's seen for the first time when patients develop COVID. But obviously they were kind of at risk for it and perhaps it would have come out anyway. Rosa, is there anything else you want to add?
Before you ask, Rosa, I've got another question for you, which you can speak to at the same time.
Okay.
The person had mild COVID, which she was treated at home in November, but from time to time, she still experiences congestion of the nose and tightness of the chest. Is this permanent?
All right, so let's just deal with the illnesses that are associated with COVID. I agree with Lucille, particularly in our first wave where there were older patients who were overweight, who had borderline or pre-diabetes, and then got COVID. And they came in severe, what we call diabetic ketoacidosis, which is a complication of diabetes. And they were particularly ill and difficult to treat. So that was the one thing. Other illnesses that COVID affected was obviously with, COVID pneumonia, which people got from mild to really severe pneumonias, warranting them to be intubated and put on a ventilator. There were things particularly precipitated by the inflammatory process that happens with the COVID infection, a predisposition to develop significant clots. So either in the legs or in the lungs or even in the brain, which would have led to some kind of inflammation or a stroke as a complication of COVID. Other things that people complained of significantly were loss of smell and loss of taste. And we've actually found that that could last from a few days after they recovered till weeks or even months post the infective period of COVID. And that largely happens because the COVID virus gets into cells in the nose and on the tongue that have something called an ACE receptor, which predisposes them to do damage of those cells and then affects that. So that slight fogginess of the nose and possible residual damage in the lung, which could lead to a feeling of tightness or difficulty in breathing, does take some time and sometimes up to months in some patients to recover from that.
Okay, thanks. Madhu, perhaps you want to take the next question. What are some of the known side effects of the Johnson & Johnson vaccine?
Yes, Prof. The side effects, we can classify the side effects of the Johnson & Johnson as twofold. We'd say it's a local. Why I mean local? Because you get the vaccine on your arm, you would have local side effects, which would include pain, swelling, and a bit of redness around where you've been injected, around the arm. And then obviously we then have other systemic, which is throughout the rest of the body. Those will include fever, chills, headache, tiredness, joint aches, muscle aches, and sometimes your gastrointestinal, which is your nausea and diarrhea. So these usually will take about 1 to 2 days. And obviously you can take a bit of medication like your paracetamol to actually assist with the pain and an inflammatory response. Why are we getting these side effects after vaccination? It's just a sign that shows that your body is building up immunity. So it's actually stimulating your immunity, and then sometimes we then get these side effects.
I think we need to emphasize the new vaccines are very safe. And I think large numbers of people have been vaccinated and support the safety data for the vaccines that we're using.
Yeah, so I think with all vaccines, you do get these sort of reactogenicity events, be it systemic or be it local. But in terms of the balance between risk and benefit, it's clearly the benefits far outweigh these sort of side effects. And most importantly, at least up until now, there isn't any vaccine, in fact, that has shown a serious adverse event or serious side effect that has been persistent. So as Madhu pointed out, many of these side effects are self-limiting. Lucille, is it correct that an employee can return to work 10 days after COVID, but only if the employee has not experienced symptoms for 72 hours?
So the first part is correct. I think extensive studies have shown that within 8 days, 8 to 10 days after the infection, after the first symptom, or patients are not infectious and they can return safely to work. They do not need a test before returning to work. In fact, the test can be misleading because it picks up little remnants of RNA and can remain positive for quite some time, and yet it's not infectious. So we use 10 days as the cutoff. As we discussed, symptoms can persist for quite some time. So it's really a time period. Uncomplicated COVID, safe to return, safe to de-isolate after 10 days, despite any minor symptoms that we've discussed.
And I think the important message there is that you can remain symptomatic for a long time. And in fact, a PCR test can continue being positive up to about 3 months. But that does not mean that you're infectious and that you're a threat to others. It's really the first 8 to 10 days after symptom onset that you're probably infectious, and perhaps even a shorter duration. But to be conservative, we're saying 8 to 10 days. Firoza, regarding tea rooms and canteens, should we close all such facilities and ask employees to bring lunch to work instead?
A difficult one, particularly for our staff that work 12-hour shifts in hospital. So what we've tried to do with our doctors is we've reduced the duration of the shifts, but let them do more frequent shifts. So, it's allowed them to not have a tea break or a lunch break in that period. But with our nursing staff and our other staff that have to work 12-hour shifts, it's a little bit difficult. So the things that we've done is limit the number of people, obviously socially distant. So we've blocked off chairs in the tea room where people could or couldn't sit. We've put in a rotational tea break system, which means that only so many people could have tea at a particular time, which then minimized the number of people that were in the tea room at any one time. And ideally, if possible, in places like the faculty or even at main campus, there are lots of outdoor spaces where people could go and sit and have tea, which would probably be the safest thing. Obviously, hand hygiene, wearing a mask while you're in the tea room and not actively eating, social distancing in those environments is what would be expected as a minimum. In that situation. So ideally, it's limiting the number of people that would be in that space, particularly if the space is small and limited ventilation.
Thanks. So it's not about shutting the canteens. People should be allowed to buy food. We don't want people to starve, but it's where you consume the food and in what environment you consume the food that's important. Thanks. Madhu, how many months will a J&J vaccine give us immunity to?
Well, the jury is still open on that question as to how many months we are going to get immunity from the J&J vaccine. We're still in the process of looking at that because currently we're still having the ensemble study going on. And we are still in the process of getting the data and see how long the immunity will last. Currently, I cannot speculate on how many months of immunity we'll have, but obviously, once we get more data and analysis is done, we will be able to give you a more appropriate answer. But currently, we're not too sure.
So I think you're correct. Like you mentioned, the studies have been taking place for a limited period of time, and we can't know the duration of immunity other than the observation period of the study. Based on experience with natural infection due to other common cold coronaviruses, we anticipate immunity to last for at least 2 to 3 years. But that obviously is also dependent on whether the virus continues to mutate. So if the virus mutates to such an extent that it becomes sort of resistant to immunity that's induced by the current generation of vaccines, it means that even that vaccine-induced immunity is not going to protect you in the future. So those are important scientific questions which we're needing to address. Another question which I'll just speak to briefly, which goes to the same theme, is what is the duration of immunity after natural infection? And in fact, what we showed in South Africa is that following infection with ancestry virus, the original virus that circulated in South Africa, infection with that virus didn't confer protection against reinfection and infection due to the new variant, at least not against mild to moderate infection. It might still have protected against severe disease. So for much of these issues around duration of immunity, both either natural infection-induced or vaccine-induced immunity, those are scientific questions that are still being answered. Next question for Firoza, perhaps. What are the dangers of a geriatric patient with known hypertension who tested positive for COVID-19 stop taking their medication, their treatment?
Right, so we've known from the first wave that older patients with comorbidities, so high blood pressure, diabetes, underlying lung disease, really overweight, are the highest risk group of elderly patients. And those were the majority of the patients that died during that first wave were older patients with comorbidities. The most important thing to remember is that if you are on any chronic medication, it is essential that, and for a chronic condition, it's essential that you continue taking your medication, 1, and 2, that you check that it's well controlled. So particularly people who were poorly controlled, both diabetic and hypertensives, were patients that were severely affected. So patients who had diabetes and high blood pressure but were very well controlled, tight sugar management, were actually okay, developed mild to moderate COVID and survived it. So I think the underlying principle to take home is that if you are on chronic medication, to take it, and secondly, to make sure with your GP or your local clinic that you actually are well controlled in terms of that illness. And that usually is what will save you from developing significantly worse symptoms.
Thanks, Firoza. So another question related to high blood, which I'll sort of answer, is it safe for people with underlying conditions like high blood to take the vaccine because getting the vaccine might raise your blood pressure, which probably is very true for men. They're probably to be more anxious when getting a vaccine, but the increase in blood pressure that you get when you get an injection is very transient. And if you are hypertensive, it's not going to cause you to collapse. So yes, even if you've got comorbidities. In fact, if you've got comorbidities, it's all the more reason to be vaccinated. These vaccines are really meant for people at high risk of developing severe disease, rather than the teenager who's going to go to a pub over the weekend. Okay, Lucille, can you explain comorbidities and the risk faced by this group when it comes to the virus and sharing of the office space? So I think it's really about the work environment, people with comorbidities, and what they need to sort of keep in mind.
Yeah, so I think we've mentioned quite a few times what the risk factors are for more severe COVID: hypertension, older patients over 60, don't forget obesity, diabetic patients of any age, and any other comorbidities, underlying illness. So I think you have to look at your workspace. Perhaps HR can chip in here and try and arrange it so that people are spaced out. There's good ventilation, and I think medical school has been looking at some of those aspects. but to really try and reduce the risks within the workspace. And I think very importantly, those who do have symptoms that might suggest COVID should not come to work. They really need to get tested, and they need to stay away from work until they're either better, the 10 days have gone, particularly if they've got a positive COVID test. So, sharing an office absolutely does pose a risk. Wearing masks in offices, I know, is quite an issue, but I think they should be applied. And I think if everybody wears one, I protect you, you protect me. And I think all of these measures can go towards reducing the risks. So I think look at your office space, look at those who are at risk, and make a plan. We really want to bring people back to work. And I think this can be done safely.
And keep those windows open and keep the doors open.
Keep the windows open.
I'm glad. Madhu, the question is, if I take the COVID vaccine, do I still need to take the flu vaccine?
Yes, the COVID vaccine just covers you for one virus, which is your COVID virus. We do have other viruses that cause your influenza that happens seasonally in this country. So it's a group of, it encompasses a whole lot of other viruses that might cause flu to actually, that might infect you. So yes, you still need to take your flu vaccine on top of the coronavirus. And the current data is showing that we might, the coronavirus as well, the COVID-19 vaccines will still be required to take those for the coming number of years, like we are taking the flu vaccine, because by the looks of things, this virus is going to stay with us for a number of years. Like, for instance, we've seen that we having a seasonal flu outbreak, and we still need to take a flu vaccine every now and then. Same thing will apply to the COVID-19 virus. That will still be with us for a couple of years, and we would still need to incorporate that together with the flu vaccines.
Yeah,
so the answer is yes to that.
Thanks, Madhu. So just to add two things to that. So in terms of the spacing of these vaccines, although there aren't studies, the recommendation is to space these vaccines by at least 2 weeks. So at least have a 2-week interval between the COVID vaccine and the flu vaccine. And the flu vaccine usually is only available over a very narrow period of the year, around about from March until May, June. And you're wanting to get a flu vaccine before the flu virus starts circulating. Madhu, you're much more optimistic than I am in terms of what's going to happen with this virus. As far as I'm concerned, this virus is here to stay throughout our lifetimes and probably beyond. So I don't think it's about a few years. It's really COVID-19 is here, which basically means we need to start learning how to live with the virus rather than believing that it's going to disappear by the end of 2021, as some of us believed might occur at the end of 2020. Unfortunately, the virus doesn't respect any calendar of any sort. So COVID-19 is very much here to stay. And the focus is really about protecting people against developing severe disease. So Lucille, perhaps to you, so it is being said, or there's a rumor that whites are less likely to die every winter from flu because they take the flu vaccine and it provides some protection. Why is there so much secrecy in South Africa about the demographics of who's dying from COVID-19, whereas racial information is usually easily available for other diseases? So is there any suggestion that any particular racial or ethnic group is being more heavily affected or less affected by severe disease and death from COVID?
So we do have some information on that. We do capture lots of parameters in the hospital group. We have the program called the DATCOV program, which looks at admissions from COVID, and it looks at demographics, it looks at comorbidities, looks at severity of disease and outcome. And this information is available on the NICED website. So unfortunately, quite a lot of information is not submitted. We always have a data issue. So, I think we're still looking at this. There do appear to be some differences. Sometimes they're socioeconomic, sometimes they are, related to where you're being treated and what facilities are available. So I think at this stage it's quite hard to kind of conclude about differences in susceptibility or risks of more severe disease. I know the geneticists are having a look at this, but I think at the moment, I don't think I can provide any conclusive comments on that. Shabir, you might have some more information.
Yeah, no, I think, I mean, certainly in other places, race has been affected. It seems to be associated with more severe disease, but there's usually an interaction between race and socioeconomic environments, where people from lower socioeconomic status, because of a variety of reasons, including issues around access to healthcare, are more likely to end up with severe disease and dying. So I don't think there's a very strong indication. In fact, if anything, the current evidence suggests that the infection mortality rate on the African continent is probably less than the infection mortality rate in high-income countries. And there's a number of reasons why that might be the case, including that the African population is of a much younger age group demographic, as well as that there might be other sort of cross-reactive immunity because of past exposures to other viruses and other pathogens that might be protecting Africans from developing severe disease. But in terms of what we call infection mortality rate, which uses as the denominator the number of people that are infected, not the number of people that are hospitalized or anything else, using that as a denominator, even in South Africa, our infection mortality rate is probably half of the infection mortality rate of many European countries. Firoza, can you speak about, so this, the variant currently circulating in South Africa is at least about 50% more transmissible than ancestral virus. What do you think about the new variant in relation to whether we require any changes to PPE?
So I think we've pretty much maintained our standard PPE that we used right at the beginning. So if you adhere to proper infection control principles, the standard PPE with your mask, with a visor if you're dealing with a COVID patient, with an apron, proper hand washing. And the actual problem is not with putting on and what you have on. It's how you take it off and how you discard that used PPE, what we call doffing. So that's usually, I mean, I've had COVID recently and I got COVID from a doffing mishap. So I think that's the important thing. The other important thing with PPE is to make sure that when you're in contact with another person or you're talking to another person, that you both have a mask on, that you both are socially distanced, because those are the parameters that will actually protect you. I know there's been a drive or some kind of suggestion that you need to double mask. If you have two inappropriate masks on and you have them on incorrectly, you can have 5 masks on and it's still not going to protect you. So the whole idea is that you have a mask that is of reasonable quality that will prevent spread or contamination, and that you have it on properly so that it forms a proper seal around your mouth and your chin and your nose. And I think that's the important factor. There's also a discussion about whether cloth masks are effective or not. And I think in our environment, again, if you have a proper cloth mask that fits properly, that has the 3 layers that we recommend they have, then, and you have it on properly and you're using it properly at all times, then that is protective and it will help. And it's essential that, particularly in our office environment or our work environment, where we're talking to people all the time, or we're working more than one person in an office, that it's essential that we do wear a mask. And that's the most important thing, rather than having 2 or 3 or 4 masks on, if that's what's being suggested around.
So the bottom line is that our PPE remains unchanged. The type of non-pharmacological interventions that we recommend remains unchanged. It's becoming more vigilant about it and making sure that there is adherence. Madhu, if you've received a COVID vaccine, can you still get infected with the virus?
Yes, you still, the possibility of you getting infected with the virus is still there. because like we rightfully did say at the beginning, it does not offer absolute protection. It just offers protection against some severe form of COVID disease, but you will probably be infected with mild to moderate disease. So the answer to that is yes, but we just are encouraging people to get the vaccines because we don't want them to get severe COVID disease, which will then put a strain on our healthcare system. But obviously, you might still get your more milder forms of the disease. So yes, you still can.
Thanks. So I'm just going to take a pause here. So we've got like about 40 other questions to go through. And I'm just going to take the prerogative of the chair to perhaps give some overarching remark, which will address at least half of those questions. So the first question relates to vaccine access. There's a whole lot of questions about vaccine access. At the moment, to be able to access vaccine, government is having a phased rollout program. During phase 1, we'll be focusing on healthcare workers and other frontline staff, and then in phase 2, the high-risk groups. And in terms of the current system, much of this management is being undertaken through the electronic vaccine register system, which is something that individuals need to register on. And then vaccine will be made available as people's turns arise. So there's a sort of registration process that people would need to undergo. So that deals with one set of questions. There is engagements between government and the private sector in terms of the public-private sector partnership to ensure that we actually get our vaccines as quick as possible. And that speaks to another group of questions in terms of WITS and when WITS will be able to make vaccines available to staff. And WITS as an institution outside of the Faculty of Health Sciences is unlikely to make a vaccine available to staff outside of the public-private partnership. So it's really for us to work through the public-private partnership in terms of seeing how quickly WITS can get vaccines into its environment. And probably for WITS, where most of our staff are on medical aids, we probably need to engage with the medical aids and the private sector in terms of getting whatever vaccines is allocated to the private sector to be made available on our environment, in our vicinity. So it speaks to another issue in terms of the staff themselves, and can staff opt out in terms of vaccination. So COVID-19 vaccines are unlikely to be made mandatory in South Africa. I think government has been fairly clear about that. In terms of the workspace, can the university insist for staff and students to be vaccinated? That is obviously a very emotive issue, which we need to discuss at some stage. But right now, there isn't any legal precedent for anyone to insist that people be vaccinated, including in the workspace. Obviously, there could be penalties that are actually introduced for those that end up with COVID-19 when they've chosen not to be vaccinated. But those are further issues that we don't have answers to right now, which the university would need to discuss. Lucille, for you, will we still have a third wave if we get the vaccine?
Yeah, I think a third wave will happen, and we've spoken about what we can expect from the vaccine, and we're not going to be able to roll it out to enough people in the population over the next few months. So I think we really have to go back to the basics, no big parties, gatherings, observe the NPIs, open the windows, and follow those rules. We can reduce the size of the third wave, and we all need to work to do that. I don't think the vaccines are incredibly important, but in the next 2-3 months, we're not going to reach enough people to stop a third wave. And
probably even a fourth wave. And I think the current sort of generation of vaccines we've got, their focus is around preventing severe disease and death, which means that people are still unfortunately going to get infected. We're still going to get these spikes of number of cases, but we don't want our healthcare facilities to be overwhelmed. And right now, we're probably already a bit too late in terms of preventing that with a third wave, because if we only start vaccinating from middle of April onwards, it's going to be some time before we got adequate penetration, even of high-risk groups. So we certainly need to prepare ourselves mentally, as well as in terms of the workspace and our learning and teaching to prepare for the third wave. Firoza, why were there more deaths with the variant? Doesn't it mean that the variant was more deadly?
So I think the fact that the variant was more infectious, that it was able to infect a lot more people than the original virus, simply on par with numbers, that there were more people that were infected, and as I said, waited significantly longer before accessing healthcare, came into hospital, in really critical conditions, and that led to people dying from it. So, if there are any lessons to be taken from that is, if you develop symptoms and you're really not feeling well, to seek help earlier rather than wait too late. There was a perception out there that if you went to hospital, you were going to die. And that was simply because people got to hospital too late. There's a point in the disease process where you try as much as you try, you can't reverse the damage that has happened in the lungs. So I think if people can know that if you do get infected, get to a healthcare facility early enough so that you can. I mean, there's so many of us that have had COVID that actually recovered from it, even though we were fairly ill with the acute infection. So yes, people die from COVID, but and those people that die are people with comorbidities, with coexisting illnesses that are poorly controlled, and that wait, too long to access the health system.
Thanks, Firoza. So we're sort of running out of time, and I'm going to ask the panelists for one-sentence answers. Not more than one sentence, and it can't be a 5-line sentence. It needs to be a 2-line sentence. So does the panel have any considerations to share with employers who are developing workplace vaccine policy to ensure a safer workplace? I think importantly from Kamini Pillay, perhaps engage with the panelists outside if you are wanting any assistance in terms of developing such a policy. Lucille, you mentioned that COVID-19 unmasked diabetes. Is this type 1 or type 2 diabetes that people are developing?
It can be either.
Okay. Madhu, can you take more than one COVID vaccine? Madhu, you're on mute. Madhu, you're on mute.
The answer to that is, I'd say yes, because we need all the protection we might get. It's just that we still are in the process of trying to find out if there's going to be any interactions. But by the data that we've seen currently, it's showing that there aren't any safety concerns. But we still need to err on the side of caution with regards to that. Yeah, what we've seen is that there are certain people who will get a vaccine that will probably not cover the variants, but will probably assist with preventing severe disease. And then you can take a vaccine that will probably cover the variants, because the virus will obviously mutate, and then that's gonna confer some form of protection with regards to the variants.
Yeah, and the other part to it is that many of the current vaccines are really targeting the same part of the virus, which is known as the spike protein. And it's very likely that even if you get one vaccine that targets the spike protein and you follow it up with another vaccine that targets the same spike protein, you're going to get what we call a booster effect. The interval between the vaccines is something which we're not too clear about. There's some data to suggest that the longer the interval between the doses of vaccine, the better the immune response. Okay, there's a question on ivermectin, and I think in fact, 3 questions on ivermectin, which I'm going to just take the prerogative to answering quickly. Ivermectin was sort of approved under special condition by SAPRA, but there isn't any scientific evidence, robust scientific evidence, which indicates whether it's harmful or whether it's actually of any benefit in terms of the treatment of COVID-19, neither whether it actually prevents infection with the virus, which is extremely unlikely. So in terms of ivermectin, unfortunately, if we want to base our decision-making on science, on scientific evidence, the scientific evidence isn't there to advocate for its use. Firoza, are you using ivermectin at all?
We haven't not prescribed it to any of the patient. It hasn't formed part of our treatment protocols at all, simply as you said, because of the lack of proper evidence.
Also, just be aware that many of the preparations that are available here are veterinary preparations and other imported preparations that are not standardized. And in an SAMJ article, which you can have a look at, many of them contain a number of other compounds, and you would be surprised by what they contain. Not all of them safe.
Lucille, while you're speaking, how many variants are known to be circulating in South Africa at the moment? And how soon will it be before more variants emerge? The crystal ball.
I think mutation is part of a virus. We're going to see a lot more. Not all the variants will survive. Some give an advantage to the virus. We have one main one at the moment with a number of different mutations. But it's very complex, and as we're sitting here, they're changing. It's the nature of the virus, I'm afraid.
Okay. There's a question here in terms of WHO guidelines for children under the age of 6 not to wear a mask. And I think that guidelines is being pragmatic in that to get a child under the age of 6 and probably even under the age of 8 or 10 to wear a mask and to actually adhere to how they should be wearing it is extremely difficult. And we know that young children are not at risk of developing severe disease. Yes, they can be infected with the virus, but they're not at risk of developing severe disease. And like I said earlier, COVID-19 is here to stay. So unless we want children growing up into their teenage years wearing a mask every day of their life, we're going to need to accept some facts, and there isn't too much of a risk to children not wearing a mask. Madhu, sorry, I'm just trying to see which ones are important. When we talk of overweight, obesity, how overweight are we referring to? Perhaps Firoza?
So it's usually people who are in the obese group or morbidly obese. So more than 25% of your base, your BMI, which is what we use as an index, would be a risk factor. Having said that, though, I've had obese patients who have no other comorbidities who've actually had COVID and are fine. So, it's not a 100% hard and fast rule. So, yeah.
Okay, Madhu, there seems to be quite a bit of hesitancy around COVID vaccines, even amongst healthcare workers. How can we overcome this high level of vaccine hesitancy?
Well, I think we have a lot of misinformation that is going on with regards to vaccines and all that, whereby people just go on social media stating their insecurities. What we need to do is, I think we need to have more sessions like these where we inform the public and our colleagues as to what the vaccine will do and how safe it is. So I think once we share that information, I think that would work in our advantage in decreasing the hesitancy of vaccines, because we all know that vaccines do work. We have what we call an EPI, an extended program of immunization, whereby we all take our kids for vaccinations without thinking twice. But when a new vaccine is being offered that will help prevent one from getting severe disease, then there is that hesitancy. But I think if we were to allay the misinformation and the fears people have, would have more people coming through and taking the vaccine. Because like we have clearly indicated, the vaccine is safe and it will help prevent severe disease.
Thanks, Madhu. So we've sort of coming to an end of time. I've got about 10 more questions. Let me take my guidance from Charles Bushley. Should we continue for another 5-10 minutes, or do you want to bring it to an end?
Prof, I think we can continue. Many staff would benefit from the information that you're sharing.
Okay. So the next question is, what is your advice regarding requirement to work from the office for employees who can work productively from home? I'm going to ask no one to answer this. There is a university policy on this, and that will be a policy from the set will be forthcoming. In fact, it's already in the public domain, in that there is a strong emphasis on returning to work, to office space for a number of reasons. Firoza, is chronic asthma in a 60-year-old considered to be a high-risk comorbidity?
So it's not on the list of high-risk comorbidities in terms of patients that to get COVID, but what we have found is that patients who have severe asthma, particularly older patients, end up with a lot more complications post-COVID. In terms of their asthma is often aggravated and needs better control. So surprisingly, even amongst people, and I'm going to get shot for saying this, but amongst people who smoke or amongst people who have had underlying chronic lung disease, it hasn't really been one of the major issues in terms of risk factors for them to get severe COVID. It's usually what we're finding after the infection that because of the damage from COVID, that they're ending up with more complications post that.
Thanks. Madhu, what advice would you give to someone who has anaphylactic reactions to certain medications, example sulfur? What do we know about the ingredients in a vaccine, COVID vaccines, and is it safe for those who have history of allergies?
Well, if you have any allergies, it's best to inform your doctors or the people that will be vaccinating you, because we do understand what is in the vaccines. Because if there is any product or substance that might elicit an allergic reaction, we would then advise you not to take the vaccine, because we do know that certain instances, for instance, some people who have egg allergies, we would not advise, because some of the proteins that are in the vaccine would cause certain anaphylactic reactions. But all in all, the vaccines are safe. But if you have a history of anaphylaxis, just inform and make sure that you inform the people doing administering the vaccine, so that we can actually check and find out if the vaccine does have any of those substances that you might be allergic to. What I could say is that we have seen a couple of people who are allergic to penicillin who have taken the vaccine and it didn't do anything. We have seen a couple of people who have been allergic to some sulfur and all that, but it didn't cause any anaphylaxis, because the vaccine does not contain those substances that will cause one to have an anaphylactic reaction. But unfortunately, we have seen that certain people who are allergic to your eggs and all that there's just one who developed an anaphylaxis, and it was found that she was just allergic to eggs and the protein that is in the.
So thanks, Madhu. Madhu, so just to clarify, there isn't any contraindication for people that are allergic to eggs to get the COVID-19 vaccines. In fact, for those of you that are more interested in the composition of the vaccines, after this call, I'll post it to my Twitter account, the composition of each of these vaccines, and you can cross-check if you've got any sort of allergies. But the important message is that if you do have allergies and a history of serious allergies, it's important that you actually get your vaccine in a healthcare facility that's adequately equipped to deal with an anaphylactic reaction. And you probably need to remain in that environment for about 20 to 30 minutes, which is usually the period of time when you're likely to experience a severe anaphylactic reaction. But generally, there's been just a handful of cases of anaphylaxis, especially for the messenger RNA vaccines, and none of those have been fatal. The question here, the next one is, can a vaccine trigger a convulsion? WHO and the Epilepsy Center has indicated that it can cause a fever. So usually seizures because of a fever is something that is more common in young children rather than adults. And sometimes in adults, yes, severe illness can trigger an epileptic episode, but generally these vaccines would still be safe in people with epilepsy, with the same sort of precautions needing to be taken.
Do you want to say something about pregnancy, Shabir?
Yes, so currently none of the studies of the vaccines in pregnant women is currently underway, but the WHO recommends that for women that are at high risk of developing severe COVID that are pregnant, they should receive vaccine from the second trimester onwards. And this is a recommendation for the messenger RNA-based vaccines as well as for the AstraZeneca vaccine, and similar recommendations will be forthcoming. The studies on pregnant women will probably be available by around about the middle of the year, around about June, in terms of the safety. But there isn't any biological reason to believe that these vaccines are going to be unsafe. And for those of you that are afraid your DNA is going to change when you get a messenger RNA vaccine, be rest assured, these vaccines are degraded almost instantaneously after they enter into the cell. So there's no risk of your DNA, and they don't have the necessary enzymes to integrate into the human DNA. So there's no risk of you mutating and growing horns. Firoza, please take us to the recommended procedure for wearing and taking off PPEs, especially the face mask.
All right, so the bottom line is, as I said, putting it on is easy. The idea is that when you take it off, you do not touch the front of the mask because that's usually the area that's been exposed. And you do not touch the inside because if you've had COVID and you've contaminated the inside. So the idea is that you do not touch either the outside or the inside of the mask, and that you remove it from the straps or the little bits that go around your ear, and you dispose of it in that way.
Thanks, Firoza. So there's a request for this webinar to be made public available. Bushle, will you post it on the WITS communications where they can access the webinar? So it will be made publicly available. Then there's a question about apparent intentional side effects of polio vaccines among teenage girls in India a few years ago. What are the prospects of such intentional accidents occurring with COVID? So what happened in India wasn't an intentional side effect, it was unintentional. The history of vaccines have been with us for more than a century now. And the number of times when things have gone wrong is not even more than a handful. So unfortunately, occasionally there are issues that creep up, especially when there aren't adequate quality checks in terms of the manufacture of the vaccine. But that's all the more reason why we need to ensure that we're getting vaccines from reputable sources. When you say that COVID is here to stay, what do you say? What do you mean? Will it disappear after 1 or 2 years? I'm not going to hopefully die in 1 or 2 years. And I said it will be my lifetime. COVID is here to stay. It's going to be here decades, and it's not going to go away anytime soon. It might change its character in terms of the type of epidemic and the type of resurgences we experience. As a greater percentage of the population develop immunity, if the virus exhausts its ability to evade immune responses, it becomes less problematic. But it's really here to stay in the truest sense of the meaning of that word. Okay, Lucille. How will VITS, I don't think this is fair enough to direct to you. No. Okay, do antiretrovirals protect against severe COVID-19? Lucille or Firoza?
Not as far as we know. I know initially there was talk of when we first came out with COVID. You know, there were lots of lots of drugs that were trialed and thought to have been successful in terms of treating COVID. Unfortunately, none of them have proven to be successful in that regard. So to date, no evidence of it, no.
Okay. So there's 3 questions in terms of VITS policy around HR issues, people returning to the workspace, as well as how VITS is going to manage the returning of students. I'm not going to ask anyone to address those questions because I think that information will be forthcoming from HR and other groups within the university. And obviously the university, the safety of staff as well as students is of paramount importance to the university. So I don't think we're going to be doing anything that is negligent. So I'm not going to ask anyone to answer those questions. And then the last question, it seems that I might have been scaring people off when I said COVID-19 is going to be with us for the rest of our lives. That doesn't mean we necessarily need to wear masks for the rest of our life. We really need to reach a good space. And the space we need to reach is that we can protect people from developing severe disease and from dying. And the way to do that, the most sustainable way to do that is with COVID-19 vaccines for people, as many people as possible, and especially the high-risk groups to be vaccinated. And once we can reduce the number of people that are at risk of dying and being hospitalized, then we can get back to a relatively normal lifestyle. We don't need to vaccinate 40 million people in South Africa to reach that point. In fact, if we can vaccinate even about 15 to 17 million and focus it on those individuals that are at high risk of developing severe disease, with the virus continuing transmitting, the problem is not infection with the virus. The problem is people dying. So yes, don't worry. It's not going to become a permanent feature of your face, and we're not going to mutate to start being born with masks on our face. We basically will be able to get over this. So I think there is light at the end of the tunnel, and that light at the end of the tunnel is COVID-19 vaccines, which, despite its limitations in terms of not being able to protect against mild infection, has got a huge value in terms of protecting people from being hospitalized and reducing the number of people that die from COVID-19. So I'm going to bring this part of the, thanks everyone for the very engaging webinar. Thanks to the panelists, and most importantly, thanks to the participants. It's been one of the most intensive number of questions we've had to deal with. So thanks for that. And hand over now to Bushley and Charles for concluding remarks.
Thank you, colleagues, and thank you for the panelists, Prof. Bloomberg, Mahdi, and Mutara, for a very engaging conversation. As I alluded to earlier, it's one of many, and we will notify staff about any further engagements in terms of this topic. The university do care about the health and safety of staff, and hence we've contracted Kahelo to take responsibility for the wellness of the staff. And I'll ask Buthler to put the slide up to just display the information. This is absolutely confidential, so it's free of charge, and the university will carry the cost of this. And it applies to both staff and immediate family. So you're welcome to use this information and contact Kahela. So once again, thank you very much for participating, and thank you for Bushla and her team for setting up the session. Stay safe until next time. Thank you. Bye-bye.